both so much. So up next, we have laboratory testing and FAODs with Dr. Nicola Longo. Dr. Longo is a professor of pediatrics, adjunct professor of pathology, and adjunct professor of nutrition and an integrative physiology at the University of Utah School of Medicine. Dr. Longo earned his MD and PhD in molecular biology at the University of Parma School of Medicine in Italy. He received residency and fellowship training in pediatrics, medical genetics, and clinical biochemical genetics at Emory University in Atlanta, Georgia. Co-director of the Biochemical Genetics Laboratory at ARUP, director of fellowship training program in medical biochemical genetics, and chief of the Division of Medical Genetics. He is an expert in inherited metabolic diseases and is intimately involved in the treatment of patients with these diseases at Primary Children's Medical Center. His basic and clinical research covers disorders of fatty acid oxidation and carnitine metabolism and the development of novel treatments for metabolic disorders, including phenylketonuria, organic acidemias, urea cycle disorders, and lysosomal storage disorders. Please join me in welcoming Dr. Longo.
Looks like you're muted, Dr. Longo.
Can you hear me?
Yes, now we can. You can go back into presentation mode. Thank you.
Perfect, sorry. Thank you for inviting me to present at the fatty acid oxidation disorder meeting. And actually, one of my primary area of research in the laboratory have been carnitine and fatty acid oxidation. And what I want to do today is to talk a little bit about the laboratory testing that is done in children and adults with fatty acid oxidation disorder, try to give you an idea why we do it and how we do it. And the first thing to understand is that, first of all, there needs to be a diagnosis. And Dr. Georgianne Arnold, I believe, already spoke about how you get to the diagnosis, but I will touch on that myself simply because we have been doing the newborn screening ourselves for more than 15 years, and I just want to provide a few key points. We also use laboratory testing in the context of management. What we want to do, we want to determine during routine follow-up how major organs are doing, and you just have seen, the heart is one of the major organs we look for. And obviously, as has been stated, if we can optimize therapy for the underlying medical condition causing the heart to suffer, we improve the health of the heart and possibly other organs. The second thing that we use laboratory testing to determine what is going on when a patient is acutely sick, and how to get the patient out of the hospital as soon as possible. Keeping in mind that the objective of laboratory testing is to allow affected individuals to recognize and to avoid complication and live to the fullest of their life. So basically, by modifying little things, we hope that people do the best. But let's go back a moment to the diagnosis. So in the old day, most people were diagnosed symptomatically. They presented with symptom, and symptom led to laboratory testing, which led to the diagnosis. What we do today is that all states in the United States and many countries around the world screen for fatty acid oxidation disorder at birth. How? Here on the left, you are seeing a newborn screening card with many blood spots. And what we do, we send this blood spot to the testing laboratory that now in every state is the newborn screening health department. And then they do the testing on the blood spot, and it can be either normal, and in such a case results are sent back to the submitter, which in most cases is a hospital or other birth facility. And in some cases, they are abnormal. And then in this case, they are called out by the newborn screening program. And depending where you are, they might be called directly to the family or to the primary care physician. Now, what is done on this blood spot? Usually, out of those blood spots, a little punch is taken out, that it is just a fraction of that blood spot. And it is analyzed with different technology. One is an enzyme-linked immunoabsent assay. And what it does, it uses antibodies to determine if something is present or absent and provide a reaction. In many cases, you get a color change, like you see in the plate on the right here, and that it can be measured by the machine to determine if somebody is affected or not. Other technology includes either electrofocusing. This is used, for example, in some type of hemoglobin testing to determine different form of anemia. In other cases, one can identify compounds based on how they are retained on a colon. And you can see an example of high performance liquid chromatography here on the right, and determine if the compound is present in normal amount or in excess. Some others do directly a colorimetric assay in which they measure the activity, for example, of an enzyme, such as biotinidase or the enzyme causing galactosemia. And obviously, if the reaction is not effective, you would see a little bit less color. But the one that it is used for fatty acid oxidation disorder is tandem mass spectrometry. What is the difference between tandem mass spectrometry and all of the rest? Each test above measures a single compound, meaning that you measure the activity of one enzyme, it is a high or low. And obviously that tells you if it is normal or abnormal. With tandem mass spectrometry, what you do, you measure many different compounds all at once. You can test for a variety of different chemicals using a single blood spot. And that it is the big advantage of tandem mass spectrometry. So in other words, this changed completely the game of newborn screening. What do we measure when we do newborn screening with tandem mass spectrometry? We measure two main classes of analytes. One are amino acids, and they become abnormal in a genetic condition called amino acidopathy and urea cycle disorder. And here are some examples that you may have heard: phenylketonuria, maple syrup urine disease, homocystinuria, citrullinemia, arginosuccinic aciduria, tyrosinemia type 1. The other one, which is more relevant to fatty acid oxidation disorder, are the acyl carnitine. And they become abnormal in disorder of the intermediary metabolism of amino acid or of fatty acid oxidation. What happens in this condition is that the abnormal metabolites are conjugated with carnitine to facilitate their removal. And these are examples of disorder that can be identified by looking at the acyl carnitine profile. They include organic acidemia, such as glutaric acidemia type 1, propionic acidemia, methylmalonic acidemia, and fatty acid oxidation disorder, such as medium-chain acyl-CoA dehydrogenase deficiency, very long-chain acyl-CoA dehydrogenase deficiency, tri-functional protein and long-chain 3-hydroxyacyl-CoA dehydrogenase deficiency, carnitine uptake defect, carnitine palpitoate transferase 1 and 2, and many others. Now, how does it look like? It looks in this way, and it looks complex, but the concept is very simple. With this type of analysis, you just check the weight of what is attached to carnitine. Meaning it's like having a scale, and you weight what it is there. And you express the weight in a mass to charge ratio. But the way that we usually express the analyte is in C. C is the number of carbon atom attached to carnitine. So in this case, this is a profile of a child with medium chain acyl-CoA dehydrogenase deficiency. And you can see that a fatty acid with 8 carbon atom is the one which is attached to carnitine, and it is the highest one in this profile. Normally this one, the C8 would be down here, and instead here it is very high. You also have secondary elevation of C10-1 and C6 here. So obviously, each fatty acid oxidation disorder has its own metabolite. Which one of them? So, for example, in primary carnitine deficiency or carnitine uptake defect, you will see that free carnitine is very low. Free carnitine is very high instead in CPT1 deficiency. In MCAD deficiency, we have already seen that C8 or octanoyl carnitine is the highest one. In VLCAD deficiency, we see an excess of C14-1 carnitine, and we see an excess of hydroxylated species such as C16OH in trifunctional protein and LCHAD deficiency. So basically, the testing by tandem mass spectrometry can tell you what it is attached to carnitine, what is the compound that accumulates because metabolism is defective, and give you a clue to the diagnosis. What one has to keep in mind that newborn screening identifies infants at risk for a metabolic disorder. It is non-diagnostic. So in other words, you need additional testing to determine whether a person, a baby, or even other people have a disease or not. Which one are these other testing? Number one, we always perform biochemical testing, which include the plasma carnitine profile, urine organic acid, and in some cases, urine acylglycine analysis. And what we do most of the time, we finish doing DNA testing to confirm or exclude the diagnosis. In the old day, we used to test one gene at a time to determine whether it was normal or abnormal. Now we test a panel of genes, and we can test all genes that we know are involved in fatty acid oxidation to see if any of them come up with different abnormality. In DNA testing, you see an abnormal sequence, but that doesn't tell you if the function of the enzyme encoded by the gene is affected or not. So what that means is that, if we look at all of us, we all differ for the sequence of many different genes. How do we know if a change that we see in the sequence is clinically significant or not? Many times what we have to do functional assay. Functional assay, they test directly the activity of an enzyme of fatty acid oxidation, or they test, they tell us the activity of an enzyme encoded by it, or they can test a full profile, for example, how well fatty acids are metabolized. That can tell us if, and this can be done in the cell from the patient, or if we have a DNA change, we can reproduce the DNA change in the gene, for example, encoding the VLCAD enzyme. And then what we do, we see if the new enzyme that contains the variant in the DNA that we have identified affect the function of the VLCAD enzyme. Let's see a moment in detail what we do with the different testing. The first one that I will review is urine organic acid analysis. Why? Because until about 20 years ago, that you look a long time, but we didn't have any other mean of confirming or excluding the diagnosis. In other words, many fatty acid oxidation disorder in the old days were diagnosed with urine organic acid. What is the advantage of urine organic acid analysis? The big advantage is that since it's been around for a very long time, we know exactly what to look for, we know what to expect, and we know what we find in different fatty acid oxidation disorder. In addition, it can give us idea if there are other diseases in addition to what we are testing, because you are not testing for a specific class of compound. You are testing pretty much for everything. And the compound that we test for derive from the metabolism of amino acid, neurotransmitter, carbohydrate, fatty acid, drugs and special diet, cholesterol, and sometimes bacterial metabolites. So if something is going on, the urine organic acid can give us a big picture of what it is happening in the body. What is the big disadvantage? The disadvantage is that many of the chemical abnormality disappear very rapidly when the child is being treated. For example, let's think a moment to long-chain 3-hydroxyacylcoid dehydrogenase deficiency or trifunctional protein deficiency. If we obtain the urine organic acid during the acute attack, they can be abnormal. If we wait that the child has received 1 day or 2 days or 3 days of therapy, the urine organic acid can be back to be completely normal. So obviously that doesn't tell us what it is going on. Now, and that it is why, and this is an example, for example, of what we see in MCAD deficiency, medium chain acyl-CoA dehydrogenase deficiency. The urine organic acid are pretty much always abnormal, and we see an excess of a compound called hexanoyl glycine, and you can see the tiny peak there that it is usually not present, and suberyl glycine that are present in children who have MCAD deficiency. This sample was obtained during an acute attack because we are also seeing an excess of saturated and unsaturated decarboxylic organic acids, such as adipic, suberic, and sebacic. So these tell us not only that this child has MCAD deficiency, but also that this child is having an acute attack. Now let's move on to the next type of diagnosis that we do. We do next generation sequencing. And next generation sequencing again sequence the DNA of multiple genes with just one single test. And for example, in this case, you sequence all of these genes here that are the ones that are responsible for the known fatty acid oxidation disorder. Keep in mind that, 10 years ago, this technology was just non-existing or extremely expensive. And the big advantage, again, you test multiple genes all at once. What is the disadvantage? The disadvantage is that the way that you get the result back is the following. You get variation in the DNA sequence that can be pathogenic or likely pathogenic. What does that mean? That based on the knowledge that we already have, the variation in DNA sequence has already been associated with a specific disease. So pathogenic or likely pathogenic means that the variant that we find is known to contribute to the disease. So we find something, we know that it is causing the problem. In other cases, we know that this variant has been reported in the general population, and we know that this variant does not cause the disease. How do we get this information? Now we have the sequence of hundreds of thousands of normal people. Obviously, if we find that a variant in the DNA is observed in 30% of the normal population, we know that that variant cannot be pathogenic. And these are the two extremes that we like to have. Unfortunately, many times when we do DNA sequencing, we get a variant of uncertain significance. What does that mean? It means that we see a DNA change, but we do not know if it is pathogenic or benign. We use different type of algorithm in DNA analysis to determine the significance of a DNA change. But those only give us a likelihood of whether it is benign or pathogenic. We don't get a definitive answer. And obviously, these are appearing more and more now that we are doing more DNA sequencing. So most of the variants that we find today are variants of uncertain significance. Now, how do we get to the diagnosis? We do functional study, and obviously we can take cells, which are either fibroblasts or blast cells from people, to determine whether the fatty acid oxidation or the acylcarnitine profiling or the activity of specific enzyme is defective. That can tell us exactly what's going on. Now, after we have seen how we achieve a diagnosis, let's go a moment what we do during our routine visit when your child goes to see the geneticist. Usually, we do laboratory testing to determine how different organs are doing, to determine whether diet and other management is adequate, and based on the results, we tend to modify diet or medication, or we leave them the same. Which labs do we do? With other testing, we like to get testing all at once, and the test that we obtain most frequently is called comprehensive metabolic panel. And we will see a moment what that includes. Additional testing includes creatine kinase activity. We can measure carnitine free and total, plasma acylcarnitine profile, and perform urine analysis. Let's look at one by one to see a moment what we get. In the comprehensive metabolic panel, we monitor glucose, electrolyte, kidney, and liver function. How and why? So the electrolyte, we monitor them to determine whether there is an excess acidity in the blood, and also if there is an imbalance in the sum of cations versus anion. What does that mean? We want to determine what it is called an anion gap, which is the amount of acidity that our body is producing. In normal condition, there is a given amount that it is produced, and if we are sick, we tend to produce more acid, and this test can tell us. So if you have a child who is acutely sick, in general, this number will become higher. If a child is managed correctly, this number stays in the normal range. And again, we calculate this from the electrolyte. The glucose level is a measure of obviously how our metabolism is doing. It can become very low in many fatty acid oxidation disorders. As probably you have heard before, low blood glucose is a late sign that something is wrong. We like to act before the glucose drops, but obviously we like to monitor this over time to see how is that doing. Then we monitor the kidney function. How? With creatinine and BUN. Creatinine is a compound which is excreted in the kidney. If a child has acute kidney failure, this value from normal, which in this case is from 0.23 to 0.61, will go 1.5, 2, 3, 4, depending on how it is going. There is not increased tendency to kidney failure in fatty acid oxidation disorder, but there can be acute dehydration that causes acute kidney failure, not chronic, but acute. Acute kidney failure is reversible, but we need to do something to reverse it. That's what it is telling us. These two numbers tell us if the kidney are functioning properly. We tend to monitor calcium level. Calcium is another electrolyte. Calcium is very important for the squeezing of the muscle and the heart, and we want to maintain this in the normal concentration. And then we start testing function related to liver activity. Which function are these? Two are called transaminases, ALT and AST. These are expressed highly in the liver and increase when the liver is damaged. So obviously they are inside. If there is something that damages the liver, they are released and they will become elevated. For example, let's say that somebody has hepatitis, like just, viral hepatitis, this number will go in the 1,000. And then as we treat the hepatitis, they trend down and normalize. Let's say that there is acute liver damage from the accumulation of too much fat inside the liver. This number will also go, they can go in the 1,000 as well. And then they will go down as we start managing the condition and the child starts improving. Alkaline phosphatase. This is an enzyme that tells us two things. One, if it is too high, it can tell us that we don't have enough calcium. Alkaline phosphatase removes calcium from the bones. If calcium is too low, calcium is removed from the bone and the activity of the alkaline phosphatase will become elevated. So it tells us if the calcium is low and if we have low vitamin D, for example. It can also become elevated if we have a problem in the excretion of bile. So one of the functions of the liver is to excrete bile. In this case, this patient didn't have any problem excreting bilirubin and other content of the bile. So in this case, the bilirubin was very low. But many cases, when this is elevated, the alkaline phosphatase will be elevated as well. Albumin and the total protein are synthesized mostly by the liver. So if the liver is not functioning well for some time, the albumin will become low. That tells us that the liver has been suffering and is continuing to suffer. This is in a nutshell what we get out of the comprehensive metabolic panel. Now, the enzyme that many people with fatty acid oxidation disorder are interested in is creatine kinase. What is creatine kinase? It is an enzyme that it is utilized by the muscle to transfer energy which is produced within mitochondria to the cytoplasm where the energy is utilized. So for example, the muscle contracts, and by contracting it needs energy. Creatine kinase is necessary to create creatine phosphate, which is the energy utilized by the muscle to function well. And this enzyme obviously is highly expressed in the muscle, and it is released when there is muscle suffering. Keep in mind that the heart is a muscle too. And obviously when there is a heart attack, the creatine kinase will be elevated as well. Now, there are different types of creatine kinase expressed by different tissue. I will not spend a lot of time on this topic, but some of them will become elevated in some specific condition. The value of creatine kinase change with age and sex. So what it is normal depends on if one is a boy or a girl, and the age, and you can see that there are ranges that really change: newborn, babies, toddlers, post-toddler, school age, and adults. Obviously, one needs to use a normal value to determine if it is normal or not. So keep in mind that even in normal individuals, if they do a strenuous exercise, the creatine kinase can become elevated. For example, I'm not physically fit. If I start running, the next several days, I will have an elevated creatine kinase. How high? About 2-3 times normal. Can it be 10,000? Probably not, but a little bit increase it can be. Now, you just finished hearing the cardiologist talking about the heart in fatty acid oxidation disorder. Now, obviously, the best way to determine how a heart is functioning is doing all of the usual testing, which is an echo and an EKG. The EKG tells you the conduction abnormality. but and the echo can tell you the function of the heart. Another way is measuring chemicals that are produced in excess when the heart is failing. And one of these has emerged, which is the B-type natriuretic peptide. This is produced in excess when the heart is having a problem. And obviously, you can repeat this testing every day. Let's say that you start treating a child who has heart failure. You can do this testing every day to see if you are going in the right direction. You can also do an echo every day, but this is much easier to do because it is a simple blood test. There are also false positive and false negative results, but mostly false positive, especially in male and female older than 75 years of age, or in patients who have kidney failure. Let's go to look at the biochemical testing. One of the tests that we do is we measure carnitine. We will see in a second what carnitine does in fatty acid oxidation disorder, but all of you know that carnitine can become very low in many different fatty acid oxidation disorder. You can see this rectal measurement of a patient with MCAD deficiency with variable compliance with carnitine supplementation. And you can see, and the green is the normal range. And you can see that when the carnitine is not taken, the carnitine level can become low. Not necessarily this is cause something good, something bad, I'm saying. But at the same time, we know that it can be reduced. We measure two different types of carnitine. One is called the carnitine free, and the other one is called the carnitine total. What are these? So I'm showing next to it an acylcarnitine profile. Anytime that the carnitine is attached to something, it is called esterified carnitine. So in this case, all of the little numbers here are esterified carnitine. If you sum them up, you get the carnitine that it is esterified in this person. If you sum the value of the esterified carnitine to the free carnitine, which is called also C0 because the carnitine is not attached to any carbon atom, you get the total carnitine. So when you do carnitine, you measure the free and total carnitine. And just to refresh your memory, carnitine is essential to transfer long-chain fatty acid inside mitochondria. Not only it is essential for doing that, but it is also the one that we use to excrete fatty acid that have not been oxidized. So if the fatty acid is not oxidized, it will go back to the cytoplasm, appear in plasma, and be excreted in the urine. And obviously, the long-chain fat that it is conjugated to carnitine will depend on which specific enzyme is defective. For example, in MCAD deficiency, fatty acid with 4 to 12 carbon atom would be accumulated in excess and be conjugated with carnitine and excreted in urine. In trifunctional protein deficiency, we have, and in LCHAD deficiency, we have hydroxylated species which get conjugated with carnitine. Again, anytime that we see them, we use this information not only for diagnostic purposes, but to see if how the child is doing. In general, if you have prolonged fasting, this compound, the abnormal compound, will accumulate in the acylcarnitine profile. And vice versa, if there is adequate nutrition, this compound will usually decrease. And when we do the acylcarnitine profile, the other thing that we look at is what happened to the rest. For example, this is the profile of a child with trifunctional protein deficiency, and you can see that many hydroxylated long-chain acylcarnitine are increased. You can see the H next to it. But the other thing that you can notice is that you can see a few more H down here. What are these? This is the result of therapy. So when you give medium-chain triglyceride in general, you increase the concentration of C6, C10, and C8, and you can see that disappear. So this child before treatment didn't have them. this child is receiving a special type of medium chain triglyceride with an odd number of fatty acids, which is called triheptanoin. How do I know that? Usually, propionyl-carnitine or C3-carnitine is normal in children who have fatty acid oxidation disorder. In this case, it is increased. This tells us that this child is taking adequate amount of medical food containing this compound. And obviously, this minimizes the accumulation of long-chain acylcarnitine. So obviously, these are the information that we obtain from the acylcarnitine profile. Is the child sick or not sick? Has the child been fasting too long? Is the child getting adequate medical nutrition? Is the child getting enough carnitine by measuring carnitine free and total? Let me show you a moment how the profile look like in a child who has either LCHAD deficiency or trifunctional protein deficiency. You see that this hydroxylated species, C18OH, C16OH, C14OH as well, are increased in this child. And obviously what we try to do with therapy, we try to reduce that. Let's review a moment what happened when we have a fatty acid oxidation disorder. So physiologically, we utilize fatty acid during fasting, and during fasting, fatty acids are released from the adipose tissue in the general circulation. They will go to the liver, the heart, and the skeletal muscle. In the liver, they are oxidized to produce ketone bodies, and ketone bodies are released in the circulation, and they spare the utilization of glucose. The body can use ketones as well as it can use glucose. If you cannot make ketones, the body will utilize more glucose and then lead to hypoglycemia. In a fatty acid oxidation disorder, what happens is that fatty acid will still be utilized, released by the adipose tissue during fasting, but once they reach the liver, the skeletal muscle, or the heart, they will accumulate inside them. In the liver, the lack of fatty acid oxidation will lead to reduced production of ketone bodies, which obviously will lead to hypoglycemia, and the brain will not have any energy, will result in loss of consciousness. In the heart and the skeletal muscle, normally the heart and the skeletal muscle, they burn down completely the fatty acid. They will have an accumulation of fat that can lead, and lack of energy that can lead to myopathy, low muscle tone, and breakdown of muscle with release of myoglobin with rhabdomyolysis and myoglobinuria. In the heart, we can have the accumulation of fat that reduce the capacity of the cardiac cell to produce energy. Sometimes it can lead to fibrosis, but most importantly, some fatty acids are toxic and can cause acute changes in the cardiac rhythm with arrhythmia. Now, the goal of our therapy is to prevent this from happening. And with some of the measures that we just discussed, we can do that. Now, what happens if the acute management is ineffective? So in other words, let's say that there is an acute attack. What do we do? So if we have an acute attack, obviously, for most people, we already have a diagnosis. At that point, we need to determine what it is wrong and how we fix it in the shortest amount of time possible. We do pretty much the same lab as we do in the chronic management, but usually you have more pronounced changes. This is a child with MCAT deficiency before we had newborn screening. At time of presentation, what was happening, this child had no measurable glucose. There was severe hypoglycemia. There was a severe anion gap. This child has severe lactic acidosis, and there was a mild increase in transaminases. Keep in mind that many times the change takes some time to become evident. And obviously, this child received therapy, and many times when you give glucose, you go into the other side, you get hyperglycemia. This child had kidney shutdown at this point. You see that the creatinine started going up. The transaminases started going up as well. And there was suffering from in the liver. Obviously, we use this number to manage IV fluid. Anytime that we give intravenous fluid, we can modify the electrolyte, and we need to keep them as constant as possible. So this is what we try to do. We try to modify the diet. We try to start feeding these children, and this should lead to a progressive improvement of the liver function. You are seeing here that the transaminases go in the right direction, and obviously that tells us whether we are doing the right thing or not the right thing. Obviously, we use this laboratory testing, not done once a week, but very frequently in the hospital, to determine even if we are doing the right thing in terms of managing children with fatty acid oxidation disorder. What does management do? Again, you have seen that it improves the level of transaminases, but it also improves the CK. These are the CK of a patient with carnitine palmitoyl transferase 2 deficiency with several episodes of decompensation. In some cases, the CK arrived to about 200,000, which is quite high. So obviously, what we do in these cases, we start providing calories and try to reverse catabolism. This leads to a reduction in the CK and sometimes an improvement in the long-chain acylcarnitine as well. Now, keep in mind that do we need to wait that there is a normalization of the CK before sending people home? Usually I don't. Once we start seeing that clinically a person is doing better, a person is eating well, the muscle pain is getting tolerable, a person is able to walk again, we do not need to wait on the normalization. Once the CK gets, like 25,000, the urine are clean of myoglobin, there is no longer the risk of kidney function, the kidney function is improving, we can send the child home. Now, one thing to keep in mind is that CK is the enzyme which is present in the muscle, but the muscle also has ALT and AST, the same enzyme that are present inside the liver. And if you have a CK of 200,000, believe me, your AST and ALT are also increased. And you can see, for example, that there is a correlation between the CK and the AST. So having an increased AST when you are having an increased CK does not mean that you have a liver problem as well. It simply means that the muscle is driving is in the driving seat, and once you have the muscle damage, you have a secondary increase in AST and the ALT. When you will clear up the muscle, you will clear up also the ALT and the AST. So do not chase number, chase the clinical activity. So, and what caused this elevation of the AST and the ALT? It is the metabolic profile. And here you show the correlation between different long-chain acylcarnitine, C14-1 in VLCAT deficiency, and the sum of hydroxylated long-chain acylcarnitine, especially with CK. CK is the one which is most sensitive to metabolic decompensation. Now, we also see that many times the carnitine level can become lower once the level of elevated acylcarnitine stay up for quite some time. Again, we use the excretion of long-chain acylcarnitine to get rid of toxic chemicals. The acylcarnitine are the tip of the iceberg. There are many long-chain fatty acids that are extremely toxic, that inside tissue that we cannot measure them yet. Obviously, the way to remove them is conjugating them with carnitine and excreting them in urine. And if we don't have any carnitine to conjugate them, sometimes we have a prolonged clinical course because these long-chain fatty acids can still not be released in urine. Now, this is pretty much what I had to say, but I am going back to some of the questions that I received before this talk. And to some of them, I believe I already answered to. For example, which lab do we usually draw in fatty acid oxidation disorder in and out of crisis? They're pretty much all the same, and they involve a combination of transaminases, CK, plus labs such as carnitine and plasma carnitine profile to determine what it is going on with the body, what it is going on with the diet, and what need to do to prevent people from going to the hospital. I did a cheat sheet that I actually added one more lab since I sent it. I'm going to send a revised one with the definition that you can use to understand what it is being done with your child when they go to the hospital or when you go to see what happened. One lab that I forgot to discuss is urine analysis. And in urine analysis, what you measure a little bit the function of the kidney. And in the function of the kidney, one of the things that you measure is hemoglobin. The reagent that we use to measure hemoglobin also react with myoglobin, which is what it is excreted in the urine in case of rhabdomyolysis. That it is why many times we just measure a urine analysis instead of measuring myoglobin, because it is cheap and fast. And once we see the hemoglobin going down and clearing, we know that there is no longer rhabdomyolysis. What do labs tell the doctor and why are they important? I hope I was able to convey some of this information, and also the difference between what we do in well visit versus sick hospital stay. We do the same lab, just that the changes that we see when the child is sick are much larger. What physical sign are doctors looking for when a child is in the hospital with rhabdo? What can parent monitor and what would be helpful? So in general, what I tell to my family is look at your child. Look how your child is doing. You know if your child is sick. If your child has a high fever, if your child has a vomiting, if your child should fast max 12 hours and you know that it is 10 hours and your child is still vomiting and still has a fever of 104, you need to bring your child to the emergency room. So obviously you need to use judgment. Judgment means, the only thing that you need to have at home is a thermometer. Usually I never tell people to check blood glucose. Blood glucose, when it becomes low, it is a late change. But that is not magic. Does not happen if the child has been eating well and doing well. It happens only if the child has been sick and not eating for a long time, or has been having, a long marathon without eating and drinking during the marathon. So that's what I tell people. So do not get any specific testing machine, just use a lot of common sense. And this is pretty much what I wanted to tell today. So in summary, what we have seen that inherited disorder of the carnitine cycle and fatty acid oxidation can present at any age when energy from fat is needed, such as during fasting, infection, and fever. Patient can appear perfectly normal between episodes for which DNA testing is necessary to confirm or exclude the diagnosis. Therapy requires fasting avoidance, low-fat diet in many cases carnitine supplementation, or special diet with MCT oil of 3-heptanoin that bypass the defect in long-chain fatty acid oxidation. Proper laboratory testing can help us make sure that the diagnosis is correct, keep people out of the hospital as much as we can, and get them out of the hospital as soon as we can if they have to get there. I thank you for your attention, and I'm ready for any question that you may have.
Thank you so much, Dr. Longo. We've had a few questions come in that we will ask. We've got about 10 minutes. So the first question is, can you explain the difference between measuring the BNPB versus troponin, and is one more important than the other to evaluate?
Okay, So the different type of BNP, how they say, what is the difference in measuring them? Can you repeat the question one more time?
Yeah, the question is, what's the difference, and is one more important than the other?
So obviously, all of them are important, and so first of all, there is another BNP that I didn't mention, which is called the basic metabolic panel. But the BNP, there are different isoforms, but both of them follow the same type of behavior. In my opinion, measuring one rather than the other, it is, they all follow the same pattern. So I wouldn't measure all of them, but just one type.
Okay, perfect. The next question is, do you do the functional test rest enzyme activity also for LCHAD TFP deficiency?
Sorry, can you repeat the question? I'm hard of hearing.
No, that's okay. I'm going to turn my volume up a little bit too. That might be part of the problem. Do you do the functional tests rest enzyme activity also for LCHAD TFP deficiency?
Usually, functional activity is done only when the diagnosis is in doubt. And most of the time it is not. Now, let me clear one thing. So there are some form of trifunctional protein deficiency that are very mild, meaning that what happens is that you can have the plasma or carnitine profile can totally normalize. If the plasma or carnitine profile totally normalize, then you start having a question. Does this child have it or not? In that case, yes, I do it. In LCHAD deficiency or severe form of trifunctional protein deficiency, where the acyl carnitine profile never ever normalized, I don't have any question. Mean that I don't do it. So does this and keep in mind that one of the bad things of trifunctional protein deficiency is that even the mild, what we call the mild variant, can be very severe clinically. So the fact that something is mild in the lab does not mean that it is mild in real life. If fast too long, they can have cardiac arrest, which is not a mild thing to have.
Right.
And that is why we want to do the functional study in those cases.
Okay, that makes sense. The next question is, how long are high acyl carnitines detectable in the blood after fasting?
So the acyl carnitine, they change constantly. So the cardiologist before me was telling, if you do twice the same exam, you never get twice the same numbers. The same for the acyl carnitine profile. Now, in general, we start increasing the level of acyl carnitine when we are functionally fasting. What does that mean? Let's say that you have, and fasting change with age and size. If you take a baby starts fasting 3 hours after the last time they finish eating. If you take me, I start fasting 12 hours after I finish eating. And the same applies to different people. So tolerance to fasting increase with age. And we start making energy from fat at different age simply because we have more tolerance to fasting. So if let's say that you take a 10-year-old child that weighs 40 kilos, fasting starts about 8 hours after the last meal. So let me go back. In a baby, the acyl carnitine start really going up 3-4 hours after the last meal. In a 10-year-old, 8 hours. In an adult, about 12 hours.
Okay, that makes sense. Can you tell us typically how long does it take to get the results back from a newborn screening test?
How long does it take? It depends on which state you are. And the first question is, do they use a courier and where you are born? Now, let's say that you live in Utah. In Utah now, we use a courier service for all the hospitals. we get the result back usually by 4 to 5 days of age. Now, many times, if it is normal, people don't get any phone call because, you know, you to tell, hey, your result is normal, you get all scared up, and it is nothing. However, if something is abnormal, usually the system is alerted much earlier than that. So in most cases, I get a phone call. Well, I get an email, not a phone call, but you know, if a child has an abnormal newborn screening by 3 days of age.
Okay, that's good to know. Yeah, so parents aren't stressed out waiting for those results, so they have an idea of when to expect those. That's great. So we have time for one more question, and the question is, would there be a benefit to repeating the urine, organic acid, acylcarnitine, and amino acids when the testing was done more than 20 years ago? Genetic studies in past 3 years shows heterozygous muta. So how often should these tests be repeated?
So in general, if the diagnosis has been confirmed or excluded, there is no reason to repeat them. I use that of secondary metabolite that tell me if somebody is taking enough oil or triheptanoate. So obviously I repeat them every time I come to clinic. So that it is what I do. But you know, each clinic does a little bit different, and some clinics only measure carnitine free and total. But in general, if something was done 20 years ago, I do it again.
Okay, wonderful. Okay, so Dr. Longo, we are so grateful. This is really great information. You know, as parents are trying to navigate dealing with their children's rare disease diagnosis and understand what are the tests they should be making sure are done, and how to understand the results of those tests is really, really important, and gives a sense of, you know, peace of mind to know exactly what you should be asking for. So we appreciate this insight that you provided. This has been incredibly useful for our community. Thank you so much for giving of your time on a Saturday to be with us. And we look forward to connecting with you more and sharing more information with the community. But thank you so much, Dr. Longo.